this is her echo. So what do you think? Does it looks like HCM? Yes. Yes, it looks like HCM. So even younger age, in the 58. So during the ventricular tachycardia, it's summation of EA wave. But if you take a look at here, it's so decreased. E prime velocities is so decreased. To compare with the preserved ejection fraction. So this is cardiac MRI, marked diffuse myocardial thickening, and diffuse intense circumferential subendocardial delayed enhancement, LGE, and the T1 value is very increased. And here, increased the ECB fraction value greater than 50% on T1 mapping images. So that means even, given that information about the HCM, the T1 value is too high, and the LG is too, extensive, and the ECV is too high. So we tried to biopsy. So they found apple-green, bioreference. So that means suspicious amyloidosis, right? So we had a gene test. So we found TTR gene mutation. So this patient is typical TTR, hereditary TTR amyloidosis with HFpEF patient. So she is treating for tafamidis now. So I think thick LV hypertrophy is not one disease. And more than 50% of the all heart failure as community is HFpEF. Ejection fraction is greater than 50%. And in thick LV patient, there's 3 different cardiomyopathies ahead. It's like as amyloidosis, hypertrophic cardiomyopathies, or the aortic stenosis, valvular heart disease, or hypertensive cardiomyopathies. There's a lot of cardiomyopathies before these patients in the HFpEF is developed. So if you take a look at these 3 patients, LVH do you think all these patients looks like HCM? Is a male, 40 years old, 27, 19 years old. This is ECG. So among the HCM population, we have a lot of different etiology of the mimicking hypertrophic cardiomyopathies. So gene testing is Dr. Nyad already stated about gene testing is really important. So guideline recommended, gene testing is recommended for all patients with HCM. And in patients with atypical cases, evaluation for other genetic cause of LVH is really essential. So we found this patient is Fabry, and this patient is Bella syndrome, and this patient is the soccer player is HCM. So it's quite different, but all those population is treating with HCM for a long time. So this is our data in our hospital, HCM clinic. We have almost in the 1,500 patient. We tested a gene test. So we found 6% of Fabry disease, and 1% of the amyloidosis, and 0.5% of MELAS, and 1 sarcoidosis patient. So if you treated the 1,000 cases of the HCM, a lot of cases hiding in your population is different etiologies. So this is really important messages about that. So next section is HFpEF. The patient often have more than one pathophysiology of the HFpEF that contribute to their clinical syndromes. So in the HFpEF, there is several cellular molecular mechanisms like structural changes, cardiometabolic abnormalities, microvascular inflammation. They can contribute HFpEF. And otherwise, hemodynamic mechanism, like as left heart congestion, diastolic dysfunction, left atrial hypertension, and the pulmonary vascular disease and volume overload can contribute, a pathogenesis of the HFpEF. So this is a clinical situation. It's a real clinical situation. 80 years old, very old, dyspnea, class 4, hypertension, diabetes, very obese, and the hypertension and the CKD, NT-proBNP elevated, chest X-ray shows pulmonary edema. It's definitive heart failure. And so we have no problem to diagnose this patient is ejection fraction is normal, is HFpEF. This patient, LVH, but contractile function is very nice, but in the pseudo-normal patterns, E over E prime ratio is 24, pulmonary artery systolic pressure is 53, so that is HFpEF. Nobody, everybody can know this patient is HFpEF. So in this patient, there's a score system, HFpEF score, and the HFA-PEF score is 4 and 6 is definitive HFpEF. It's okay. But what about now? This patient, 74-year-old woman, and dyspnea, and hypertension, and the NT-proBNP level is 59, and obese, and sinus rhythm, and the no pulmonary congestion. Can you diagnose this patient as HFpEF? It's not HFpEF. Even she has dyspnea on exertion. This is her echo. LV hypertrophy. E over E prime ratio is about 12. LV systolic pressure is normal range. LV GLS a little bit decreased, but it's okay. LA volume index is a little bit enlarged. So we scored 3 and 3. Its probability is less than 5 and 0.5. And in the major criteria, is not matched in the HFpEF diagnosis. We performed this patient in the diastolic stress echo. So this patient, in the even 25 exercise, during the supine bicycle exercise, E prime velocity is dramatically increased, but E prime velocity is not increased. Take a look at here. When the low dose exercise, RV systolic pressure is from the normal to 68. In this kind of population, even small, exercise, dramatically increased RV systolic pressure. There's no change of the E prime, the elevated E over E prime ratio. That can predict, future HFpEF patient. So diastolic stress echo is we already demonstrated the prognostic implications. Exercise-induced pulmonary hypertension, and those kind of patients have poor outcomes. In this patient, 6 months later, she admitted in the heart failure by emergency room, and she really have a dyspnea and orthopnea, and the NT-proBNP level is elevated in the congestion. So she admitted several times after this, stress test. So there's a lot of imaging modalities for diagnose and HFpEF and predicting future outcomes. So next one is, what is the imaging marker for diagnosis of the HFpEF or predicting prognosis of the HFpEF? So the next one is LVGLS. If you take a look at here, this is a preclinical dysfunction, and the HFpEF and heart failure reduce the ejection fraction. LV ejection fraction is getting lower from here. And the circumferential deformation is, in the early stage, is over, exaggerated. After then, they decreased. But if you take a look at here, in the longitudinal deformation, even they have a preclinical dysfunction, they already decreased. So in this preclinical stage, they have, abnormal LV-GLS. So that is really a good marker for early detection of the progressive LV dysfunction. So there is some data from the, a lot of, data show some evidence of the LV-GLS can predict future outcome. This is from European Journal of Heart Failure. The HFpEF patient in the decreased GLS less than 16 in the predicting future poor outcome. And what about this? In patient with the left bundle branch block, so can you measure ejection fraction very accurately? No. Sometimes it's really difficult. Or sometimes patients who have a pacemaker, it's really difficult. In this population, more than 1,000 patients who underwent a pacemaker implantation, so ejection fraction is quite, preserved. In those population, LV-GLS is decreased, less than 11. Let's have a poor outcome. And what about this? And a patient who had a surgically treated mitral valve, prosthetic mitral valve, we cannot measure E prime effectively. So in this population, also we shown, very good, predicting a poor outcome using the global longitudinal strain. So this. And also LV-GLS is less load dependent than ejection fraction. All these patients, this is our data, is an ESRD patient after kidney transplantation. In the baseline, more than 83% patients have a normal ejection fraction, but they already reduced LV-GLS less than 20%. So the more decreased LV-GLS, after kidney transplantation, they have a poor outcome. So even looks, normal LV systolic function as a normal ejection fraction. As LV-GLS is lower, those patients have poor outcome. And what about in the next section, novel imaging marker for heart failure with LVH with preserved ejection fraction? So first one is LA reservoir strain. Is really important. If you take a look at here, in the normal LV function, early stage 1, late stage 1, early stage 2, even EA ratio and the E over E prime ratio and the LA volume index is comparable. The early stage 1, they already, LA strain is decreased. So that is really, early marker in the changing of the, diastolic function. So this is a paper about the left atrial reservoir strain and the LA compliance allow for discrimination of the HFpEF from the non-cardiac dyspnea with a greater accuracy. So it's a really nice, paper. It's about left atrial strain. And what about in the moderate AS patient? Even patient with moderate AS, patient who have lower LA reservoir strain, they have a poor outcome. And next one is diastolic reserve. The diastolic reserve is a simple parameter. Is exercise, supine bicycle exercise. Diastolic reserve is E prime velocity during exercise minus E prime velocity at rest. So there is patient A and B, and this patient A is during the exercise, E prime velocity is gradually increased. But this patient is not changed that much. In this population, its diastolic reserve is very decreased. And this patient have more symptoms, more increased NT-proBNP, and more poor, adverse outcome. So diastolic reserve is a very sensitive marker for the, predicting patient outcomes. So we tried this to IDEA trial in the SGL2 inhibitors. And the placebo-controlled prospective study, and we did a diastolic stress echo in the placebo group and the dapagliflozin group. And this is the diastolic reserve test. So after 6 months of the placebo and the DAPA group, the diastolic reserve is significantly improved in the SGL2 group compared with the placebo group. So SGL2 inhibitor is really works for HFpEF patient or early diastolic dysfunction patient. The last one is RV pulmonary artery coupling index. It's really a little bit complicated, but it's a very sensitive marker for the pulmonary circulation and heart failure with the preserved ejection fraction. So this is my last take-home message. Non-invasive imaging plays a crucial role in the diagnosis of the LVH with HFpEF. Particularly, it's not high risk in the intermediate risk scores. And LVGLS is a valuable marker in the HFpEF patient because it sensitively assesses LV systolic function and has prognostic implications. And the LA reserve strain, diastolic reserve, and RVPA coupling index are emerging tools for evaluating HFpEF patients with LV hypertrophy. Thank you for your attention.